Well, the talk is titled Don't Tell Me You Are Seeing Double. What you're actually dealing with is diplopia. Well, before I start, I request you all don't please tell me that you are all feeling sleepy. I know it's already 1:15 and you've already been dreaming. Soon it'll be 1:30 and a delicious Kerala lunch is awaiting you. Hi, I am Dr. Shaji Hussain. I am the cornea consultant at Al Salama Eye Hospital, Perindalmanna. And yes, it indeed, maybe I'm the odd one out being here as a cornea person among the neuro-ophthalmologists. And the story of how a cornea person got a talk in a neuro-ophthalm CME is a big story. Well, let me come to the topic proper. To begin with, when you have a patient who's got diplopia, it always begins with a good history taking. In history taking, we have to see if it's a sudden or a gradual onset. Gradual can be soon after sleep or when the patient is just tired. But when it's sudden diplopia, it's having a red flag. Talking about if it's a monocular or a binocular diplopia, monocular can occur when the case is a case of cataract, when you have a media opacity, or because of ectopia lentis, that is usually unilateral when the patient is closing one eye. But if it's present even in binocular view, that means yes, he's got something in a red flag sign that can include nerve palsies or mechanical restrictions or even in myasthenia gravis. Next, is the diplopia comitant or incomitant? Comitant means the diplopia will be the same in all cardinal positions of gaze. That means it can be some anatomic causes or some decompensated phoreas for that matter. But what gets the red flag is the non-comitant diplopia. That is, the diplopia actually varies at different positions of gaze. Again, we have to tag it with neurogenic, myogenic causes or mechanical causes of diplopia. Well, if it's associated with diurnal variation more in the evenings, then it has to be myasthenia kept in mind, and also associated systemic diseases of diabetes has to be ruled out. In the examination part, we look at the head posture of the patient, examine the orbit and the lids. Extraocular movements have to be assessed. The pupil reaction has to be kept in mind. Any causes for a neuromuscular junction disorders, also assess the associated cranial nerves. In head posture, we have to look at the face turn. This is more common in horizontal muscles. Head tilt, more common in oblique muscles. And whether there is chin elevation or not, that is usually seen in bilateral cases. In orbit, we have to look at is the thyroid eye diseases. Extraocular movements, we have to look at both ductions and versions in all 9 cardinal positions of gaze. Pupil is involved when there is young patients with compressive lesions in the brain. Neuromuscular junction disorders, we have to think of myasthenia gravis. Cranial nerves, we always have to look at the 3rd nerve, 4th, 6th. Also the other associated cranial nerves like 5th, 6th, 5th and 7th, and also the 2nd nerve. Well, also associated examinations include assessment with the prism, assessment with the Maddox rod, assessment of diplopia charting, and also duction tests. Prism will be actually prism bar cover test. Maddox rod also includes double Maddox rod evaluation, diplopia charting, and force duction tests to look at mechanical causes. Well, the reason for this talk actually coming up is this will be mainly concentrating on Hess chart and a tip on Park 3-step test so that it can be easily remembered. Starting with Hess chart, my idea is to give you a basic interpretation idea about when you see a chart of Hess chart from a clinical perspective. To start with, I remember my resident days when we used to have the DNB appraisal exams. Hess chart was an important thing. And our seniors used to console us, there is nothing to worry, or just look at the smaller field, whichever is the eye with a smaller field, which will be the diseased one. and to say whether neurogenic or mechanical, just bluff something and you may get it right. And the more I tried to learn about it, it was getting tougher or even more confusing. So when I got this talk, I actually did a small survey. I asked a few of my residents also in their first year, and also a few of our optometrists, showing them this chart. Well, to my surprise, most of them did say that, sir, this looks like something like a visual field valuation. Some said this looks like an Amsler's grid. Some even said this looks something like an ECG, looking at those squares they're seeing. Well, friends, Hess chart actually has mainly two things represented in the chart. There is an outer square that is at 30 degree and an inner square at 15 degree of ocular movements with a plus sign at the center. We are assessing both the eyes in the same chart, so we have left eye represented to the left side and the right eye represented to the right side. It is tested with the goggles on. It's not just plain goggles, it's actually the red-green goggles. It is the green goggle, that is the eye with the green goggles in front of it, that is the testing eye. How to assess Hess charting? Hess charting, we have to hold the patient's head steady with the red-green goggles on. In this case, the right eye is being tested. At the examiner's side, he is actually changing the position from one point to the other so that the chart will represent the points accordingly. And on the other side, you can see the patient pointing at the chart in which he is seeing the red light with the help of a green torch. And here in the fourth picture, you can see where the examiner has shown the red light and where his green lighter is pointing. It is done at a distance of 50 centimeters. So to begin with, or before coming to the interpretation, let me just tell you, for the right eye, this is how the muscles are supposed to be acting. We have a superior oblique at the levo depression, levo elevation, we have the inferior oblique and the superior rectus and inferior rectus. We have to keep this orientation with the patient looking away from you. So here we can see the patient, when the patient is looking at the Hess chart, this is how the muscles have actually been placed in the right eye. And along with this, we should know that when the patient is looking in the left eye, this is how the muscles would be projected. It's just that the superior and inferior obliques are on the nasal side of each eye. And also don't forget the horizontal muscles, that is on the nasal side we have the medial rectus and to the lateral side we have the lateral rectus for the abduction. Well, explaining the Hess chart, we know there are a lot of small squares. Each square is representing 5 degrees. So in the inner field, we have 3 small squares. That tells us it is around 15 degrees from the center of the primary fixation. So this is the inner field. Then another 3 small squares, that makes another 15. So it's around 30 degrees is the outer field assessment. So now this is how when the patient is for the right eye, this is moving the eye to in the adducted position. This is when the patient is looking up, that is in the levo elevation for the right eye. This is levo depression. Levo depression, we have superior oblique. Now this is abduction. We have the lateral rectus. We have dextro elevation, that is superior rectus. Dextro depression, we have the inferior rectus. Explaining the chart again, we have the right eye on the one side with the green before the right eye sign. That means the right eye is being tested. Similarly, for the left eye, we'll have green before the left eye. We'll have the patient's name and MRI number mentioned. When the examiner is pointing the light at the center, the green was pointed higher. When it is in the abducted position, the green spot was higher. When it was in the levo elevation, the green spot was even higher. When it was in the levo depression stage, it was even higher, not as high as the other one. Then the points are joined. Well, what all do we diagnose with the help of Hess chart? The neurogenic causes of assessment is third nerve palsy is assessed, fourth nerve palsy assessed, sixth nerve palsy is assessed. The mechanical causes that can be assessed with Hess chart is orbital floor fracture, Duane syndrome, Brown syndrome, thyroid eye disease. Yes, you have got it right. We are actually assessing squint with the help of Hess charting. But the problem is that in this squint, the deviations are varying at different positions of gaze. So it is actually, to be more specific, it is concomitant squint. So when you look at the Hess chart, there are a few things we have to look at. So this is the Hess chart of the right eye and the left eye. So how do you start approaching the chart? First, to start with, we have to say which is the smaller field. In this case, it is the right eye is the having the smaller field. So that is the diseased eye. Now, is there a compression in the diseased eye? That means is it compressed horizontally or vertically? If it is compressed, it will be mechanical causes. We have to find out in the right eye now which is the underacting muscle. In this case, it is the lateral rectus. And then which is the overacting muscle. So now coming to an example, now this is the same chart. Now we know this is the right eye is having the smaller field. There is no compression noted. So this can't be mechanical cause. So the next thing we have to assess is now which is the underacting muscle. We know here in the right eye it is the lateral rectus because the outer field is way inside and the inner field is also another 2 squares, that is around 10 degrees inside. So it is the lateral rectus is the underacting muscle here. The next thing we have to look at is which is the overacting muscle. So in the left eye, that is the contralateral synergist is the medial rectus which is overacting in the left eye. The primary position of the eye can be assessed with that central plus sign dot, wherein we can see that from the central point the eye is deviated inside in the right eye. So it is an iso deviation for the right eye. With regard to the shape of the Hess chart, there is no specific A pattern or a V pattern that is being noted here. So this is a 6th nerve palsy of the right eye of a recent onset. Coming to the next chart, here we have which is the smaller field, it is in the left eye. Now, is there a compression seen in this eye? No. So this can't be mechanical causes. It has to be neurogenic. That means it's 3, 4 or 6. Now, which is the underacting muscle? It is the superior oblique of the left eye. We can see the inner field of the superior oblique part is deviated up. Who is overacting? That is the contralateral synergist. In this case, for superior oblique, it is inferior rectus of the right eye. Position is V pattern is noted. You can see there is an extortion in the left eye and an intorsion in the, there is an extorsion in the right eye and an extorsion of both the eyes, in the right and the left, wherein there is a V pattern. So this is a left 4th nerve palsy of recent onset. Next is this is the right eye is having a smaller field. So there is no compression noted. The underacting muscle in the right eye is the inferior oblique. We can see the deviation. The overacting muscle is the contralateral synergist. That is the superior rectus of the left eye. There is a hypodeviation in the right eye partially. Shape, there is no significant change. So this is a right partial 3rd nerve palsy of recent onset. Now the next thing, which is the smaller field, it is in the left eye. is having the smaller field. There is no compression noted. The underacting muscle is the superior rectus of the left eye, as seen by the mark. The overacting muscle is in the right eye, that is the inferior oblique. So here there is again a hypodeviation of the left eye, no particular shape noted. So this is the left partial third nerve palsy affecting the superior division. Now this, you can see the size of the fields are the same. So this can happen in this case it is because of underacting superior obliques that can be seen in both the eyes. It is more noted in the left eye. So since it's symmetrical, or the paralysis of the same muscles are noted, we can see that the hyperacting contralateral antagonists are the inferior rectus of the either eye. So this is a bilateral fourth nerve palsy. The next is another a condition in which we can get similarity in both the fields are when there is a spread of committance in a long standing palsies. Now this, to give an approach, we know it is the right eye is having the smaller field. There is no compression noted. The muscles with the normal action here are the lateral rectus and the superior oblique in the right eye, which means all the other muscles are underacting, which is actually pointing towards all the muscles supplied by the third nerve. So this has to be a case of total third nerve palsy. Coming to the compression part, when there is a compression, it has to be mechanical causes. So what are the most common mechanical causes to look at? Now in the left sided chart, you can see the left eye is actually compressed. That is, it is a horizontal compression. In the second chart, you can see it's compressed vertically. So this is a vertical compression. So what is the first chart pointing at? Is it an orbital floor fracture? No, it can't be, because orbital floor fracture actually underacts the vertical muscles. So here it is the horizontal muscles. So this has to be Duane's syndrome. Now in the second chart, again here you know it is the vertical muscles that are restricted. So then the causes of mechanical causes, it can't be Duane's or Brown's, so it has to be orbital floor fracture. Thyroid eye disease also stands as a chance, but the problem is we have to confirm it clinically. Coming to Park 3-step test, coming back to the actions of the muscle. Now this is, as you know, how the muscles are placed in the right eye and the left eye. So we have the superior oblique as a levo depressor for the right eye, levo elevator for the right eye is the inferior oblique. So 3 questions to ask. Hyperdeviated eye in primary gaze, which is the eye. Vertical deviation is more in which gaze? Not the eye that is deviating, it is the gaze in which there is a vertical deviation. The third question is vertical deviation is more in which sided tilt. So to coming back to it again, hyperdeviation is in the right eye or the left eye. Which gaze, is it in the right gaze or the left gaze that the vertical deviation is more? And is it in the right tilt or the left tilt that we get a more vertical deviation? Showing an example here, as the right eye is covered, we can see that the left eye is coming from up to down. That tells us the left eye is hypertropic in this case. So we place the L here. Then when we look at the second video, we can see that when the baby is looking to the left, there is no hyperdeviation noted. But when the gaze is shifted to the right, we can see the left eye is going up. So that tells us it is in the right gaze that the patient is having a hyperdeviation. So we tag an R here. Coming to the third video, I didn't get the head tilted position of this baby, a clear video. So what I thought was I will borrow another person's video. But imagine that this is the same patient. So when the patient is tilting his head to the left, we don't see any deviations. But now when the person is tilting his head to the right, apparently nothing is noted. But when the alternate cover test is done, you can see that the left eye is coming from a hyper position. So we can tag it as an R. So it will be a LRR. So now coming to the L. So when would the left eye go up? Either the superior oblique or inferior rectus has to underact, or it can be a hypodeviation of the right eye, that is when the superior rectus or the inferior oblique is underacting. Now with that placed, now we talk about the muscles involved in the right gaze. It can be the superior rectus and the inferior rectus of the right eye, or the inferior oblique and the superior oblique of the left eye. In the third position, in the head tilt, we have to see the muscles involved in the right tilt and the left tilt, and the right eye and the left eye. Right eye, it will be the intortus, that is the superior rectus and the superior oblique. For the left eye, it will be an extorsion that is happening, so it has to be either the inferior oblique or the inferior rectus. With this, we diagnose muscle that is been rounded 3 times is the diseased muscle. So in this case, it is the superior rectus of the right eye that is involved. Another clue is the eye that is having a triangle formed in front of it will not have the affected muscle. All the other muscles in the right eye is being marked as only once. That's another confirmation clue if the pattern drawn is right or not. Well, so when we talk about the right eye, we have a superior rectus, inferior oblique, superior oblique, inferior rectus as the vertical muscles. Superior rectus has a code of LRR, as we have already seen. Right superior rectus is LRR. Inferior oblique is LLL. Superior oblique of the right eye is RLR. Inferior rectus is RRL. Similarly, for the left eye, inferior oblique, superior rectus, superior oblique has respective codes. What's difficult is here, we will not have the time to deduce this according to our findings. But if you have this code ready, LRR or LLL ready, and if we had some easier technique by which we can directly come to the muscle, then it would be saving a lot of our time. So what I thought is, for the exams, we can have a code remembered or some simpler way to remember things. So to start with, LLL and RRR, wherein all letters are the same. The muscle here would always be inferior oblique. So now the next question to arise is, which side inferior oblique? If it is LLL, it will be the other letter, that is the right sided inferior oblique. If it is RRR, it will be the left inferior oblique. Coming to the next muscle, that is the oblique again, that is superior oblique. Here it will be the middle letter will be different, that is it will be RLR or LRL. So the first letter will represent the side of the muscle. If it is RLR, that means it is superior oblique of the right side. If it is LRL, it will be the left sided superior oblique. So now we have excluded 4 muscles from the list. Remaining are the superior and the inferior recti. For the superior rectus, the last 2 letters will be the same, that is RR or LL. So the first letter, the opposite to the first letter will be the side of the muscle. So if it is LRR, it has to be a right sided superior rectus. If it is RLL, it will be the left sided superior rectus. Another way to remember is the majority of letters would represent the side of the muscle. LRR means there are 2 R's, so it can be a right sided superior rectus. Next is, what remains is the inferior rectus. Inferior, though it is inferior, the first two letters are similar here. That means if it is RRL, the first letter will talk about the side of the muscle. So it means it is the right inferior rectus. So inferior oblique, right side left eye, RRR and LLL. RRR is the left sided inferior oblique, LLL is right sided inferior oblique. For the superior rectus, again the first letters will be opposite. That means the last two letters will be the same. So RLL will represent a left sided superior rectus. Also for LRR, it will be the right sided superior rectus. For the superior oblique, the first letters will represent the side of the muscle and the middle letter will be different. For the inferior rectus, the first two letters. With that, I thank my mentors, Dr. Srinivas K. Rao and Dr. Muhammad Sadiq, for being a wonderful clinician, wonderful surgeon, and all the more a wonderful teacher to me. Thank you, sirs. And thank you all for your patient listening.